I have the pleasure of reminding us first of actually I have a couple of slides to come up, of reminding us of our keynote speaker and reminding us of who Dr. Robert Moreton was. So while we're waiting for that slide to come up, I want to remind us about our name lectureship and where that came from. Robert Moreton was born in Mississippi in 1913. He attended Millsaps College in Jackson, Mississippi, and then went on to study medicine at the University of Tennessee, where he earned the degree of medicine in 1938. This was followed by radiology training at the Mayo Clinic from 1938 to 1941. His first practice was at Scott and White Clinic in Temple, Texas, where he remained until 1950. He joined the Bond Group in Fort Worth, where he practiced until 1965. During this time, he was on the clinical faculty at Southwestern Medical School. In 1965, he joined the staff at the MD Anderson Hospital and remained there until 1984. Dr. Moreton made significant contributions to GI radiology. He was active in statewide health issues and was appointed by 6 different governors to significant voluntary positions. He served for 24 years on the Texas Board of Health. In 1988, a new building in Austin was named in his honor. He was active in the Texas Radiologic Society and was president of the TRS at the time of the 39th annual meeting held in Houston in 1952. He was awarded the gold medal in 1974. He received the gold medal of the RSNA in 1973 and the gold medal of the ACR in 1992. Dr. Moreton was a board member of the John S. Dunn Research Foundation, a large philanthropic group. In 1945, he married his wife and lifelong companion, Alma. Dr. Moreton passed away at 79 in 1992. After his death, the John S. Dunn Research Foundation donated grants to the TRS and the American College of Radiology to underwrite an annual Robert D. and Alma Moreton lectureship. So with that, I want to introduce this year's Moreton lecturer. Dr. James Reinertsen heads the Reinersten Group, an independent consulting and teaching practice focusing on improving the clinical quality performance of healthcare organizations. He is also a senior fellow at the Institute for Healthcare Improvement in Boston, where he develops and delivers several of IHI's programs for boards, executives, and physician leaders. The winner of the 2011 John L. Eisenberg Individual Achievement Award for his decades of American and international leadership for clinical quality and safety, Dr. Reinertsen has an unusual combination of skills and experience. He practiced internal medicine and rheumatology for 20 years and has also been an influential and admired health system CEO, leading healthcare quality improvement in medical groups, hospitals, and academic health centers. He was a CEO of Park Nicollet Health Services in Minneapolis from 1986 to 1998, and CEO of a 6-hospital system in Boston from 1998 to 2001. Dr. Reinertsen was a founder and first chairman of the Minnesota's Institute for Clinical Systems Improvement and is a former board member of the American Board of Internal Medicine, as well as the former chairman of the board of the American Medical Group Association. He is an honorary fellow of the English National Health Services Institute for Innovation and Improvement, the author of over 60 scholarly papers and a 2005 book titled 10 Powerful Ideas for Patient Care Improvement. Dr. Reinertsen is a graduate of St. Olaf College and Harvard Medical School. We are honored to have Dr. Reinertsen deliver this year's Moreton Lecture on the topic, Possible or Passable, Setting Aims for Accountable Health Care. Dr. James Reinertsen.
Well, thank you very much, Dr. Applegate, and good morning, everyone. It's an honor to be invited to give this lecture, the Moreton Lecture. Looking at the list of past lecturers, certainly I find myself humbled, but I also want to note that when the American College of Radiology gives one an invitation to give a lecture like this, it's particularly gratifying because of this college's history of dedication to quality. You have not made quality sort of just a tagline on a marketing campaign, and I'm particularly impressed by your emphasis on appropriateness and your brave stance. I have to say that your brave stance on the quality dimension, the quality problem that is usually encapsulated by the term overuse. So thank you for that, and thank you for this invitation. Today I want to talk about three things. First of all, I want to say that the problem that we are facing with our national economy is coming to bear on healthcare in ways that it never has before. To make a sort of a blunt statement about it, if I were Joseph interpreting the dream for the Pharaoh, I would say, Pharaoh, we're entering the 7 lean years at this particular point in time. And I want to talk a little bit about how that came about. I then want to describe 3 choices that I think you face, we all face. The choice between victimhood and leadership in response to this challenge, that's choice number 1. Choice number 2, whether we want to do it for ourselves or whether we want it done to us, which is sort of something in parallel to the choice between victimhood and leadership. And the third choice is about setting aims for the quality agenda for the future, and whether we want those aims to be towards what's acceptable, passable, or whether we want to aim high and take some risk and aim for the possible. So let's talk about this problem of value-driven, accountable healthcare. We all say that is what healthcare is moving into. Let's look into how we got there. I need to start with sort of a microcosm of the healthcare system. The little valley in Wyoming and Idaho where I live. I live about 8 miles from the town of Driggs, Idaho, in Alta, Wyoming. And in Driggs, Idaho, there's this little critical access hospital called Teton Valley Healthcare. Looking in the paper this summer, I noticed some big announcements and advertisements and news stories about this new medical imaging capability that has now been purchased and installed and ready for operation in this little hospital. It's important to note that with all of this going on, the average daily census of this hospital is 3. On a really busy summer month, there may be 2,000 or 3,000 people total in a space of 30 or 40 miles by 15 miles in this rather remote part of the Mountain West. What can we say about this? Why did this hospital do this? Very straightforward. They need the money. And they know that if they build and install a facility like this and run it and the volumes are adequate, they will have a higher level of profitability. The truth is, and I can say this about every organization that I ran for the 15 years I was the chief executive of some complicated systems, that the key driver of our financial success or any health system success is volume, especially volume of high-margin services such as imaging, laboratory testing, and procedures. Your CFO, to put it bluntly, is happy when you have a busy month in the OR, when you have a busy month in imaging services, and concerned when the volumes drop off. Now, here's the problem from a quality perspective. Some of those high-margin services that are delivered in your, not all, but some, are provided as a result of avoidable complications of care. We call that the quality problem of misuse. Something went wrong, so we had to bring the patient back in for procedures and fixes and treatments to deal with what went wrong. Could be a postoperative infection, could be a complication of a interventional procedure of some sort. The point is that it's costly, and it also brings in a lot of revenue for you, although it's costly to the public. For many other high-margin services, the problem that you've been working so hard on, the potential for harm, excessive radiation in your case, outweighs the potential for benefit. Some 30% of all imaging services, your own college has said, are the result of overuse. That's the category we're talking about here. Let's look into each of those a little more deeply. Potentially avoidable complications have been studied in a number of ways. This is a study from a major employer that had a large population that they were insuring, and they looked at all the diabetics in their population and said, so how many services were consumed, how many dollars were spent in care of those diabetics? And they said, oh, $1.32 billion of services in our population was spent on diabetes-relevant services. Then they asked the question, of those 1.3 billion, how many of those services were due to potentially avoidable complications? Example, an admission to hospital primarily for the diagnosis of diabetes out of control. And the number was staggering. 800 million of the 1.3 billion was spent on potentially avoidable complications, probably because too little was spent in the green circle on the things that are evidence-based required services for patients with diabetes. That's part of the problem. But still, this really raised everybody's eyebrows, especially when they looked at a long list of other diagnoses and found that for CHF and coronary artery disease and COPD and asthma and hypertension and hip replacements and knee replacements, bariatric surgery and so forth, overall, more than 40% of all costs in their payout for care every year were related to what were defined as potentially avoidable complications. The other category where you get a lot of your volume from is this problem called overuse. And you've had a lecture from Elliot Fisher, I noticed, in your series of Moreton lectures in the past, and he's far more eloquent than I and did much of the basic work involved in putting together maps like this that show the variation from one part of the country to another in the number of services and the cost of those services offered to Medicare patients. And you can sort of see sort of the south and eastern parts of the country and some pockets on the West Coast where relatively high utilization exists. The north and western parts of the country seem to be sort of a desert here of low volumes of services relative to those in Miami and sort of other hot spots of care. And the question is, well, are those people up in the northwestern part of the country getting, poor care? And the answer is actually no. All the evidence that's been amassed so far suggests that more is not better. That in those areas of high utilization of services for Medicare patients, there's worse adherence to guidelines on evidence-based practice. There's higher mortality for common conditions like acute MI, hip fracture, and colorectal cancer. If you ask doctors, do you think the care in your community is good? Actually, the doctors in high-utilizing communities think it's not as good as communities like Minneapolis and Portland and Salt Lake City. And if you ask patients, do you get good quality care? The perception of care is actually worse in Miami and McAllen, Texas, than it is in Salt Lake City and Seattle. Let me just pause and say that let's acknowledge that our costs in the United States are not just about what doctors and hospitals do. We have extraordinarily high administrative costs. A recent study in the journal Health Affairs showed that U.S. doctors spend 4 times as much in overhead costs dealing with private insurers than their counterparts in Canada do. I think that's actually an underestimate, but they were trying to be conservative in their judgments about it. We also have much higher malpractice costs than most other developed countries, and we pay higher prices for pharmaceuticals in this country than they do in most of the rest of the developed world. But you need to sort of zero in on the doctor part of this for a second and take a look at ourselves. We're paying a lot in the United States for doctor's fees. By the way, don't yell at me about this. I'm just reporting the news and the weather here. This is data that is now available to the policymakers here in Washington, and they've taken notice of this. In the United States, we're spending about $1,600 per year per person on doctor's fees, whereas in the rest of the OECD countries, the 24 countries that we most commonly compare ourselves to, they spend less than a quarter of that on doctor's fees. If you look into the detail, there was a recent study done in Health Affairs that looked at primary care and orthopedics. They didn't look at all specialties. I don't have data for radiology here. They compared what is paid per unit of service for primary care and orthopedics in Australia, Canada, France, Germany, the UK, and the US. I've just highlighted the US numbers here. For both the public payers, in the United States case, Medicare and Medicaid, In England, it'd be the NHS versus the private payers. And all of those countries have private payers as well as public payers. In the United States, you can see it's $60 per visit for primary care and $133 per visit for in private cases. The only other country that comes close to that in rates is the UK. In case of orthopedic surgery, it's $1,600 for a hip replacement from Medicare or Medicaid, and about $4,000 for hip replacement for private payers. And no other country comes close to that in the case of orthopedics. How does that translate into incomes? And you can see that in the United States, the typical, this is from the year 2008, the study was done, typical primary care, a doctor was averaging $186,000 per year in income, which is significantly north. The only country that comes close to that is the United Kingdom with $159,000. And in orthopedic surgery, the gap was even greater. $442,000 was the average salary, and typically half of that in most of the other countries. So the policymakers are looking at this. By the way, you might ask the question, how does it look for radiology? I happened to look up the MGMA radiology numbers for 2011, and the median was 471,000, 80th percentile 579. I have no idea what those numbers are in those other countries. Maybe you can talk to some of your friends and figure that out. Here's the summary of this. The net effect of all that high-priced volume, and that's what's coming through in the current policy debates. It's not just all that volume, it's the high prices that are associated with that volume, is that a decade of healthcare cost growth has basically wiped out real income gains for the average family. As Jeff Goldsmith, last year's Moreton Lecture, told me once, he said, even the insured can no longer afford our services. They're being priced out of the market, making decisions with their high deductible health plans saying, maybe I don't really need to get that thing looked into, whatever it is. We're looking at taking a family vacation. We'd like to buy a new bass boat. Do we really want that knee looked into, that if it's going to cost that much? Now, there's really no easy out this time around. We've worked our way through this sort of problem in the past. But this problem of the national debt just won't go away. Our national debt just passed $15 trillion, and our GDP is about $15 trillion. This is a danger signal. All the economists who've been studying, economies of countries around the world for years have said that the risk point where they start to get concerned is when a country's national debt gets to about 0.8 of its GDP. We're sort of moving, we're not there yet, but we're moving towards the status of Ireland and Greece and Portugal and God forbid, Japan in terms of this ratio. And it's not a good place to be. You've got to do something about it, everybody says. And the biggest thing we have to do to solve this problem is healthcare spending. It's 43% of our federal spending. And the Dean of American Economists in this field, Victor Fuchs, says, here's the deal. If we solve our healthcare spending rate of growth problem, practically all the rest of our fiscal problems go away. Conversely, if we don't solve our healthcare problem, then almost anything else we do will be completely irrelevant. So healthcare is squarely in the crosshairs. And I think if you look at healthcare policy, I don't care who gets reelected next year, and the next time around, and the next time around, healthcare policy for the next decade or more is all going to be focused on cost reduction. That's a prediction I think I could make with some confidence. So what's already being done to try to reduce these costs? Well, one of the big things that's happening privately is increased cost sharing in plan design. You've all experienced this. This is the family that used to have first dollar coverage that's now sitting at the kitchen table saying, gee, can we afford to have this knee surgery? Can we afford to look into this particular problem? It's going to cost us a lot in out-of-pocket copays and deductibles. And Mayo Clinic put in a very modest co-insurance kind of an option for their own employees, where they said they have 10 to 20% co-insurance costs for imaging services, specialty services that weren't primary care prevention, laboratory tests, and so forth. And it led to a large and sustained decrease in the rates of utilization of those things. This has been observed over and over again. I've given you a reference here from Health Affairs just in November. The radiology business management companies, I'm sure you're all painfully familiar with, most physician practices now have to get approval for them for advanced imaging studies on commercially insured patients. It's sort of become the norm. It's now coming out over to Medicare, and you saw the announcement that MedPAC takes aim at imaging overuse. Basically, they're saying, look, if 10% of providers are ordering 50% of all imaging studies, let's require some of those overutilizing or potentially overutilizing orderers to have to get prior approval before Medicare patients can get their images. You've done a lot of work on this. Your appropriateness criteria are really helpful in guiding the decisions about who should and shouldn't get x-rays and other imaging studies. But there's that's not going to be enough in a lot of people's view. Broad brush reduction in fees for all doctors in this country, I think, is something that we can sort of anticipate. You've seen the back and forth on this. There was supposed to be a 28% reduction here this last calendar year starting January 1, negotiated back a little bit better for primary care than it came out for specialties. But do you think that's going to stop? That's sort of pressing backwards on fees rather than letting them continue to escalate. It's happening on the hospital side. It's happening on the doctor side. You've already mentioned, I've heard mentioned this morning about the MPPR rules and what's going on there, another effort to reduce these payments. And more broadly, beyond the world of radiology, perhaps, changes to the overall payment model, where for your medical practice or for your hospital system, you potentially get so-called bonuses. They're not really bonuses. They take the money away from everybody and give it back to the top couple of quartiles, or the top quartile of providers. That's not really a bonus. It's a deduction from everybody who didn't earn it. But it amounts to a couple, 3, 4, 5% potentially of your overall Medicare payments. In addition, when you add to that penalties for bad performance, like readmissions or hospital-acquired conditions, you can get up to 9 to 12% of your overall Medicare revenues at risk for how well you do on measurements of quality and safety. More interesting, actually, are the experiments that are going forward in bundled payments, where, for example, all services by all providers for a hip replacement from the period of 1 month prior to the operation to 6 months after the operation are put into one bundle and put out as a budget for all the providers providing those services. That's supposed to cover the orthopedist's costs and all the visits and the surgery and the work and whatever, the hospital's costs, the device that's implanted, all radiology services, pre, during, and post, and the rehab costs if the patient winds up in a nursing home for the entire 6 months because things didn't go very well. It's out of the same budget. It actually changes the dynamics dramatically about how doctors and hospitals work together with each other in deciding what are the right set of things to do for a patient with a hip replacement, and what can we do to reduce the potentially avoidable complications. Under that model, your business managers are going to be more concerned with PACs, potentially avoidable complications, than they are with RVUs. It's going to shift the dynamic from generating RVUs to reducing PACs. The ultimate version of that is sort of a budget payment for your population. Accountable care organizations, capitation, these are sort of words for the same general concept. The affordable care reforms that came from the Obama administration didn't really want to call it capitation, so they called it something else. But it's basically managed care and drag, the accountable care organization idea. It's not popular or politically correct to call it managed care, but that's what it was and is intended to be implemented. Anything to lessen the administrative burden associated with private health insurance has not been on the table. I kind of find this a bit puzzling because some people estimate that as much as 30 to 35% of the overall cost of care in the United States is simply due to the administrative complexity of having a private health insurance model. All those people in your back office, the hospital's back office, the back office of all the insurers, they're being paid to push paper around that could be done much more efficiently and simply if we didn't have that complicated model. We also never put meaningful malpractice reform onto the table in the past rounds of reform, and I think that's something that could have been done as well. As far as the insurance is concerned, I just have to make a side comment. This is my cynical view of the business model of Aetna and United and WellPoint and all the rest of the big insurers. Basically, you contract with all of you guys and your colleagues and the hospitals and the nursing homes and whoever. You don't really change the delivery system very much. You sell a card that gets access to you, you collect money from the customer, and then delay paying all of you who deliver the services as long as possible. It's called playing the float, by the way, without changing anything significant about the rate of growth, the cost, or the quality of care, and there's a lot of evidence on that. But you do cause mind-boggling administrative burdens for everyone. I don't get it, why we are supporting this model so strongly. It's, this emperor is looking very naked. And the value-added proposition here is increasingly suspect. And I think we ought to be considering that. So that's the situation. If I were speaking to the Pharaoh now, I'd say, look, Pharaoh, we're going into the 7 lean years. What should we do? The first choice we face is whether you want to be a leader or a victim. You might say, woe is us, there goes the neighborhood. I'm just going to keep my head down. I got 10 years left, and then I'm just going to get out of practice and let them deal, and somebody else can deal with this. That would be a victimhood stance, not a leadership stance. A leader accepts the reality of the situation and deals with it. Says, all right, our business model is soon going to be driven by value, not by volume. What do we need to do in order to succeed? All right, that's the situation. Now, what do we have to do in order to make it happen? Best way to think about this is to use this sort of 2-curve model that many of you might have seen before. We're on the first curve. This is the volume curve. If you do more stuff to people, if you do more services, provide more of everything, generate more RVUs, you get more success. That curve, like all business model curves, eventually sort of runs its string out as sort of a new business model comes along. The new business model is the second curve. And initially, it doesn't look very attractive. In our case, it might be called taking bundled payments or capitation payments for some portion of our patients, or being at risk for the care for a population of patients. Hey, we're doing real well on the model we've got right now, building more imaging centers in Driggs, Idaho. Maybe we should just stay with it for a while. And the truth is, when you first jump from curve 1 to curve 2, you actually lose something. And the question is when to jump. Do you wait until it's too late? Or do you jump early and forego some of the revenue potential of the first curve before you switch to the second? It's a difficult choice for leaders in many businesses. I was working with talking with a major publisher of magazines, U.S. News and World Report. They've jumped from first curve to the second curve. I don't know if you've noticed, but they don't publish magazines anymore. They publish reports on colleges and healthcare and a variety of other stuff. They've completely jumped into a new business model. And I said the real marker for them was when they knew they were going to go to the second curve was when they basically sold their printing presses. The devices that printed, their paper copies of the magazine. And the question for healthcare is that I'm going to ask you is when are hospitals going to start selling their CTs? That's sort of the equivalent, or at least some of them, if they've got too many right now. When will the Driggs Hospital sell its CT and imaging services that it just sort of put in, and if so, at what point? That's what jumping onto the second curve might look like if, in fact, there are too many of those things in the system. One of the questions that you'd ask is, what are the handicappers saying about this? Is this going to work? Is the second curve, this accountable care organization thing, actually got a shot? Well, Don Berwick, who recently stepped down as CMS administrator, thinks it has a shot. And you'd say, well, he's expected to say that. He was in the administration and trying to make these things happen. But his view is that, yeah, you could do well doing this. Jeff Goldsmith, who talked here last year, in the same interviews in the Wall Street Journal in January, says, look, it's like asking the hungry horse to guard the granary. No, you got to get real about this. And you heard Jeff last year. You'd know how he speaks about these things. To get savings in this deal, hospitals and specialists have to turn their backs on 5 decades of making more by doing more. Scully, who also has spoken in your series, says, wait a second, the problem that happened here with ACOs, it was supposed to be about doctors getting back into control, and the hospitals have co-opted the thing because they got all the capital. But he says, the hospitals don't really have an interest in this. Have you ever met a hospital administrator who wants to work to empty his beds? By the way, closing wings of a hospital would be another marker of jumping to that second curve. It really would. There's an argument that can be made for that. Here's my view of that whole discussion around accountable care organizations is that there is a real strategic opportunity for us as providers in this discussion. And it's this. If we, the doctors principally, in a community, were to work together systematically to prevent complications, that's the potentially avoidable complications bucket, and to reduce overused services, the traditional health insurance model would be seriously threatened because people would begin to wonder, they weren't doing it. The traditional health insurance model wasn't getting it done. The doctors are getting it done for themselves. Why do we need the insurers? Why do we need Aetna and United and all those other guys getting rich, basically with this game called the float on the healthcare system? This is the question, do you want to do this for yourself, or are you just going to sit back passively and have it done to you? That's the challenge. I think we could step up and do this. And it would require, it's not easy, by the way, to do this task. It would require something called true clinical integration. I've written about this with my colleague Alice Gosfield from Philadelphia, and we defined it as physicians working together systematically, with or without other organizations and professionals, to improve their collective ability to deliver high-quality, safe, and valued care to their patients and communities. I can't sort of explain this diagram in its complete form, but I can at least summarize it, that what essentially would be involved in creating a true clinically integrated system would be changes in form, changes in finance, changes in function, and changes in feeling or culture of the organizations in which you work. Many of us have remember, although it's not so prevalent today, the old world, if you look at the far left column, where basically doctors didn't actually work in any sort of system, they just happened to work in the building of the hospital or the clinic or whatever it was, and basically worked for themselves. They were paid individual fee for service. Their job was high quality care for individual patients, and their feeling and the predominant cultural mode was individual responsibility, fierce attachment to autonomy. We're now well into an era where doctors are either employed or partnering with each other and with the hospitals and other institutions. Our financial models are changing towards evidence-based case rates, bundled payments, pay for performance in stronger and stronger fashion. Our job has changed. The function that we're supposed to perform is high-value care, not high-quality care, high-value care. So eliminating the overuse and the potentially avoidable complications, as well as delivering the needed services for specific sets of acute and chronic disease patients. And that's going to require team accountability. You have to work together with other specialties in a way that we've never done before in order to accomplish that, and a significant degree of patient and family empowerment. The far right-hand side of this column looks a lot like what I see in Sweden. I do a lot of work in the Scandinavian countries. I'm taking a group of CEOs over to visit them in a couple of weeks to study what they're doing, because they've been doing accountable care for decades. They have community ownership by county commonly, or by region, not by country, but I like the smaller unit of ownership. They work on the basis of population-based budgets. They work against target, which would broadly call the triple aim: best quality care, best quality service perceptions on the patient, by the patients, and lowest possible cost. And the culture is sort of a community responsibility. Patients feel some responsibility. The care team feels it shares this responsibility. But it's not sort of an individual autonomy, doctor knows best sort of a culture. I often give organizations the opportunity to audit themselves. Are they capable of moving towards this sort of a model? Are they capable of moving to the right-hand side of that chart you just saw? And if you took the specific environmental features that your organizations are facing, you can look at just the simple value-based purchasing propositions around core measures and surgical care, improvement practices, and primary care, chronic disease, pay for performance. What do you have to do to win at that game? Well, you have to be able to improve processes. You have to be able to use reliability science, it's what is broadly termed. You have to have good coding and documentation and measurement across a broad spectrum of practices. You have to have chronic disease registries and use a good chronic disease model like the Wagner model. It's pretty basic, but a lot of organizations don't even have that. Then if you add to that penalties for healthcare-acquired conditions and safety events like infections and decubiti and medication errors and surgical complications, readmissions and never events and the like, you need everything I just mentioned in the previous slide, plus you need a comprehensive approach to safety, a very, very organization-wide, complete, deep approach to safety. Even fewer organizations I know have this. You'd also need specific programs for your most high-risk patients. I call them clinics and nurse management programs that come under a variety of headings for reducing these sorts of complications. When you get to bundled payments, where you get like one check for all services from 30 days prior to 6 months after bariatric surgery or knee arthroplasty, and there are some other examples listed here. You're going to need everything on the previous two slides, plus you're going to need clinical integration with the necessary professionals and services. This is what you'd have to have for your practice and the people that you practice with as serving them in the radiology community. You need to know where your current costs and potentially avoidable complications are occurring. Now, you know where they are inside your own hospital, but you don't know what happens, by and large, when they go out into the community. The health plans do because they keep a claims database, but you need to know that information. Once you know where the complications are, you need to have the ability to reduce them. You need to have patient-centered redesign of services. You need to have control of service capacity. So what that means is, let's just say a new group moves to Driggs, Idaho, says, we're going to set up shop in this little valley town in the mountains. We like the fishing, we like the skiing, it looks great, let's set up a business here. And they decide to open up a second imaging center. The system would have to be able to say, you know what, we've already don't know that we need the first one we've got. It certainly may not be necessary to have a second one. And would say, no, you'd have to be able to control the capacity of new services in your system. I look at organizations that are putting together ACOs, and they're bringing in, let's say, urology practices that have radiation oncology in the practices. And I say, do you have the ability to say no to that? Are you going to include them in your accountable care organization? Because if you are, you're not going to win. You can't build excess capacity and then hope to control it later. Because if you build it, they will come, and it will be used, is sort of the history in healthcare. You're going to have coordination of referrals and outside contractors. You're going to have to send patients to the people who are relatively conservative in their practice styles. Do you know who they are? Would you dare do that? And, with you in the radiology community, how are you going to deal with that with the people who refer to you? You're going to have to accept and distribute bundled payments. I think this is the most interesting problem of all. So the check comes into your organization for all the services from 1 month before to 6 months after a hip replacement. How much money are each of the providers going to get out of that check, and who's going to decide? Well, there's an interesting question. One of the things that you're going to need here is alignment of individual provider performance feedback and incentives with the bundled payment model. And by the way, I called up several of my colleagues and acquaintances around the country to say, how are you doing this now? And I got this example. I will not identify the organization. I said, how do you pay your radiologists? And the fellow said, we pay our radiologists a salary set at 70th percentile of a compensation survey we use. I said, what is that number today? The answer was $571,000. Sounds pretty good. I said, do some radiologists get more than others? He said, no, they all get paid the same amount regardless of the RVUs generated. I said, wait a second. He says, no, it's just like I said, whether they're doing interventional or all these new gizmo procedures, or whether they're just reading chest x-rays, they get the same amount. I said, why do you do that? He says, well, we want them to sort of just focus on doing the right thing for patients. We don't want them to have any incentive to do things to patients that is not necessarily just driven by what they professionally think they need. So we pay them a good salary and tell them to do the right thing for their patients. I said, how does it work out in practice? He said, well, our radiologists are fairly aggressive they do a consult, not just accept a referral. They will tell an ordering physician to get a different test if they think it's a better idea. They have no volume incentive, so they can focus on what's right for the patient, not on their paycheck. I thought, by the way, this was a particularly good field model in line with the oath that I heard your new fellows taking in their convocation last night. Basically, I'll commit myself to doing what's right for the patient above all other considerations. If you get to the full-blown version of this, a budget for a population, either by attributed costs, by actual capitation, the ACOs and other population health models, you'll need everything on the previous 3 slides, plus you're going to have a clear understanding of what's called actuarial incidence risk, because you're taking risk not just for the cost of care once a person gets sick, but you're taking risk for whether they get sick as well in the first place. You're going to have reserves against those sorts of risks, and financial pots of money against sort of big swings in cost for your population. Enrollment and communication systems for communities, public health and disease prevention systems. By the way, at this point, you're starting to look a lot like Sweden or a lot like an HMO, one of the two. So there's a kind of the first 2 choices you face, or do you want to just sort of roll over and say, woe is me, I can't deal with this, or do you want to take a leadership stance and say, let's take this on, let's do what we can to make it right for our patients and to do well for ourselves despite all of these changes that are happening because of the economy. Second one is, well, if developing integrated systems is one of the answers to that, do you want to just sit and wait for it to be done to you, or do you want to take a leadership role in making it happen? The third choice then that you face is, as you put one of those things together, what are your aims? Are you going to aim for what's passable or aim for what's possible? And here I'd like to sort of end with a challenge to the American College of Radiology about your aims. You've been so good in the past about raising the bar for our profession. Here's an opportunity, I think, to take it even farther. What do I mean by passable? If you look at the dictionary, good enough, adequate. The aims, in the case of quality aims, would be framed using what's required by regulation, what's expected, the norms. Those are what we call touchstones. The possible, however, is sort of defined by being within the limits of ability and capacity of realization, but being something that may or may not occur. It's framed using the unexpected or even the theoretical ideal as something which I've learned to call a reach stone. I'll explain that in a little bit. On an individual level, passable is sort of meeting your requirements, keeping your job, where possible is really stretching. It involves some risk, but it also involves some excitement. Organizationally, staying in business. Keeping regulatory people away from the door, ticking the boxes on the various inspections and so forth is fine, but the possible is real innovation, growth, change, maybe even jumping to that second curve. I happen to throw this in. Nationally, Passable will be getting reelected. Possible will be making history. Let me illustrate this from a personal basis. As I said, I live out in the mountains. This is the Grand Teton. It's about 4 miles as the crow flies to the summit from my house. And I gave myself for my 60th birthday, a guided climb of this thing, which by the way, it's the last time I'm ever going to climb a mountain, but that's a different story. I'm going to take you to this spot that I've put the arrow on right here. It's where I sort of got this concept of a reach stone. There's a place there called the Step Across, and you have to reach for a handhold that you cannot see. This handhold is out of your vision. Your guide says it's there. You know that your foot has nothing to go on. If you can't see this rock face that's there, it's absolutely smooth granite. There's nothing to put your foot on. And the thing that's going to help you get through this is you've got to get to that, and you have to step into thin air and hope that your hand is going to get this thing. When you get there and look down, it is 1,100 feet straight down. It's about as exposed as it gets in this part of the world. That's a reach stone. There's risk involved. And I would like you to think about a reach stone in the area of diagnosis. If you look at the history of quality and quality improvement in healthcare, much of our work has been on improving the process after the diagnosis is made. A person has diabetes now. Are they getting all of the things they should get? How do we make sure they get their foot exams and their eye exams and all like that? Much of the measurement, much of the public policy, to be honest, is on what happens after the diagnosis. A patient has CHF. Now how do we treat them properly so they don't wind up coming in and out of the hospital all the time? A patient has some surgery for something or other. What's our process for preventing an infection like that? I think, and many others are starting to work on this as well, that the next frontier for the broad quality improvement community is going to be the quality of the diagnostic journey, something that you in the American College of Radiology have been working on for a long time. And you have an opportunity to really lead this thing. The current diagnostic journey is largely unmeasured, it's highly variable, and it's expensive. We are also then coming up against the opportunity against rapid advances in technology and genetics and telecommunications, social media, and patient-centered care design. And it raises the possibilities, it raises the question, what could be done? What could be possible for the diagnostic journey? We've faced this in my organization back in about 20 years ago at Park Nicollet with the question of breast cancer and the number of sleepless nights that a patient who has just been told by a doctor at some stage of the diagnostic process, we think you might have a problem. How long did it take from that moment until the moment that the woman had an answer, one way or the other, you do or you don't have breast cancer? We did a measurement of it, and we were shocked to find it was 3 weeks. 3 weeks of sleepless nights in our wonderful practice. So this is what happened. I won't give you the whole story, but with the advent of some new technology called stereotactic biopsy, a remarkable level of cooperation and redesign of systems and services between radiologists, primary care doctors, general surgeons, and everybody else who was part of the system, we were able to get it from 3 weeks to 3 hours. Answer in 3 hours. And it's been consistently done that way ever since. I call that sort of, and by the way, one of the 6 dimensions in the IOM report on quality from a number of years ago was timeliness. Timeliness of diagnosis is one of the factors. Accuracy, how much does it cost to get, how many false starts and false trails do we go down in the process? These are the sorts of questions that I'm asking about the diagnostic process today. First of all, did they need us at all? Could patients have done this for themselves at home? And many companies, by the way, are looking to bypass all of you and give the diagnostic tools to the patients. I don't think it's too long before patients will be buying a $14.95 ultrasound device and sort of, at the Walmart and running it over their abdomen and sending some picture in someplace to get a reading. I really don't. I don't think it's far-fetched at all. How many doctor visits does it really take to get to a diagnosis of rheumatoid arthritis or multiple sclerosis? Which doctors should be seen? How many laboratory tests? how many imaging studies would be really necessary? How many procedures, biopsies, and endoscopic exams? Ideally, how long would this whole process take? And ideally, how much would the whole process cost? I think this sort of set of questions, not just about the parts that are radiologically involved, but about the whole process integrated with the primary care docs and other specialists, would be a very, very important set of questions for us to start answering. Here's the reach stone. Why not make a standard that we would reach for of 0 sleepless nights? I know it sounds ridiculous in many instances. In some cases, it's probably out of reach because for many conditions, the best diagnostic test is careful observation over the passage of some time. But for others, the 3 weeks in our situation in Minnesota was simply because we had old rules that doctors had to get permission from the primary care doctor to do anything else. The radiologists weren't empowered to go on and do the studies they thought were necessary. They'd have to send a report back and say, we recommend future things be done, and then it would be processed in the primary care office and it would be sent back. And the long and the short of it was all that backing and forthing was actually just causing more and more sleepless nights. It wasn't about new technology as much as it was about better coordination of care and better teamwork around the diagnostic process. So that's the challenge I would put out to you. Why not set a target of 0 sleepless nights in the diagnostic process and start working towards that target with your colleagues in your communities across all specialties, not just in radiology. Some years ago, when I was tempted to sort of fall into a funk about some things that were going wrong for me, my secretary, who had worked for me at that point for about 10 years, brought this statement in on a brass plaque, little wooden framed thing, and she said, here's a gift for you. And I said, oh, great, I'm going to put it over there on that table where all the doctors come in and complain to me all the time about one thing or another. And she said, no, put it on your desk facing you. I don't know if you got a secretary like this, but I needed that. It was sort of like a little bit of a wake-up call. I think of this as the most elegant no-whining sign in history. And it's actually, I think, apt for this moment in time for all of us in our profession. This is the true joy in life, to be used for a purpose you consider a mighty one. And I'll just put no sleepless nights on that one. Say, you nominate one if you want to take one that's come up with something that's stronger than that. I think that would be a great one. To be a force of nature, rather than a feverish, selfish clod of ailments and grievances, complaining that the world will not devote itself to making you happy. Like that was ever supposed to happen. So that's a summary of my view of this particular stage in our evolution in American healthcare. I would say, if I were speaking to the Pharaoh, I'd say, sorry, sir, we're entering the 7 lean years. You need to store up things in your granary and so forth. Our choices, as we look at this, are either take a leadership stance or lapse into victimhood. I think the clear best option there is to take the leadership stance. If clinical integration is truly what's necessary, the question I pose to you is, are we going to just wait passively and let it be done to us, or are we going to take the lead? And I clearly prefer that we take the lead. And I would challenge you to go for the possible. Don't settle for the passable as you set your goals for quality improvement in the future. Thank you.